Good morning. So we're going to talk about the new medications that we're going to be adding with all the new protocols that are coming out, hopefully end of July. There's 3 brand new medications. There's 2 medications that you're familiar with that just come in, we're going to be using in a different form. So ketamine and rocuronium are going to be your alternative RSI drugs for etomidate and succ. They're going to be in addition to. The biggest reason why we're adding these is because last year there was a national shortage of etomidate, so I don't want us, and there have been numerous drug shortages recently, so I don't want us to get into a situation where we're not able to RSI because we don't have the drugs available. So these are alternatives to those. Amiodarone is going to be replacing procainamide, so we're going to take procainamide off the trucks. It's a drug that's safe to use in WPW. And then epinephrine is going to replace the dopamine drips. It's easier to use. It's not weight-based dosing. And then Zofran ODT is an orally dissolving tablet that will have, in addition to the IV Zofran, you just put it on the tongue and it dissolves. So it's good to use in kids that you don't want to have to get IV access on, and it's also good because you can't throw it back up. So ketamine is a drug that was originally used as a sedative in veterinary medicine. Ketamine, you can actually do surgery on people and animals with ketamine because they keep breathing. So it's used a lot in veterinary medicine for that reason. It's a dissociative anesthetic at high doses to where people will be completely unconscious. And it also, in lower doses, affects the pain pathways and provides relief for anxiety. So that's one of the reasons why it's going to be good for RSI. The indications for ketamine, you can use it, and the dosing is the same. You can use it for RSI just like you would etomidate for an induction agent. You can also use it for post-intubation sedation. So after you intubate, if the patient is still biting the tube and fighting, you can use it for sedation during transport. You can use it in the ROS protocol, and you can also use it in one of our new protocols, which is going to be the induced hypothermia protocol. The one thing ketamine is not approved for yet that we're hoping to get in the next year is the treatment for excited delirium. It actually works really, really well for excited delirium, but the state is not really comfortable with it yet. We're hoping that once we start using it for RSI and they realize that it is safe to use pre-hospital, that we'll have permission to use it for treatment of excited delirium. Two of the things that ketamine does that might be of benefit for certain patients over others is that it causes bronchodilation. So it might actually be better for a patient with COPD or asthma. It also causes an elevation in blood pressure. Unlike any of the other induction agents, which make your blood pressure bottom out, this one actually causes a increase about 20% of your blood pressure will go up. So it might be good in like a trauma patient that's already hypertensive, or even a medical patient that's already hypertensive, and as soon as you push the RSI drugs that they're going to bottom out their pressure. With that being said, if you choose etomidate over ketamine, nobody's going to fault you for it. So it's really just a backup drug for you to use as an alternative, but nobody's going to say, well, why did you use ketamine or why did you use etomidate? You can use either one. The third thing that it does is it causes less suppression of respiratory drive. That's not really going to be an issue for you guys because you're going to be paralyzing them, so you're going to take away the respiratory drive anyway. But it's something that we take advantage of in the hospital where we might intubate somebody without a paralytic who we know is going to drop like a rock as soon as we give them meds. So like I talked about before, the patients that might benefit from ketamine over etomidate would be your asthma patients, your COPD patients, and your hypertensive patients. Complications of ketamine. I don't think that you guys are ever going to see laryngospasm, but I want you to be familiar with it just in case, because sometimes as soon as you push the ketamine, you'll get this. I've only seen it personally one time. It's a pretty rare complication, but the treatment for it is the paralytic. So as long as you've got your paralytic ready to get on board, then you're fine. It may take 20 seconds, and it's a little scary because you hear like the worst stridor you've ever heard. But that's why we're not using just ketamine in the field. So this is what laryngospasm looks like. So this is what you see when you try to intubate somebody with laryngospasm, and you'll hear stridor, and you cannot get a tube through that. The one patient I had with it, I was actually intubating with a glide scope, so I could see, and everyone in the room could see all this. But then we pushed sucks, and it went away immediately. All right. The other thing with ketamine is that sometimes you'll get what's called the emergence phenomenon, and I know the handout that Brian sent about ketamine talks a lot about emergence. The emergence phenomenon is where you give, usually happens with lower doses of ketamine, so you don't have the patient completely out. We see it with conscious sedation. We use ketamine for conscious sedation in the hospital, and it typically happens in teenage boys for whatever reason. Where when they start waking up, they're hallucinating and they start fighting their hallucinations. So it's basically like a bad trip. Ketamine is basically PCP. It's a cousin of PCP. So it's basically like the bad trip that everybody talked about in the 70s. The third thing about ketamine, and this is the reason why it's going to be kept in the narcotic box, is that there is risk of diversion with ketamine. It is a drug of abuse. Okay, I have a slide on that. So, ketamine on the street is referred to as usually special K or KET. It can be taken, usually people take it IM because it gives them a longer high. They also will evaporate it and make it into a pill. And sometimes it's sold as ecstasy, so people think they're taking ecstasy and they're actually taking ketamine. It can also be taken PR. The big thing with ketamine, I haven't seen any of this at Lexington yet. I've seen it in Greensboro and I've seen it in Winston, but haven't seen it at Lexington yet. But it may come up. The biggest thing is to treat the respiratory depression, which isn't, usually that profound, but just give them some supplemental oxygen. Don't try to, there is no reversal for this. It wears off. And then anticipate the emergence because they may wake up fighting you or whatever weird things that they think they're seeing. Anybody have any questions about ketamine? Okay. Yeah. Ketamine will give you a good 20 to 30 minutes. There's a pretty good variability with ketamine person to person, but most people you'll get a good 20 to 30 minutes. So hopefully the rest of your transport. I'm working on whether or not we're going to be able to redose it or not. I think we'll be able to, but I've got to get that approved by the state to be able to redose it during transport. But yeah, you should have good 20 to 30 minutes. So rocuronium is the first non-depolarizing paralytic that has a fast enough onset of action to where it's safe to use in RSI. So all the other non-depolarizing paralytics like vecuronium, pancuronium take too long for their onset of action to really be safe to use in RSI. Rocuronium is about 30 seconds, about the same as sucks. So the dosing for rocuronium is 1 mg per kg. We're doing that just to keep it simple. That's what the protocol is going to say. It's easy to remember. The actual dosing is 0.6 to 1.2. So most patients, you can get away with just using the 50 milligrams because it comes in a 50 milligram vial, which will treat up to about a 90 kilogram person. So I use 50 in almost everybody unless I have a really big person. So if you go a little bit on the low side, I'm okay with that. If you want to do the 1 mg per kg, that's fine because that'll give you a little bit longer action of the paralytic, which might be beneficial during transport because you can't redose the rocuronium. So if you want to go, on the high side, that's fine because it will, like I said, it'll keep them down a little bit longer. The one thing to remember with rocuronium is that because it is a longer paralytic, make sure you give plenty of sedation because you don't want to be it'd be pretty awful for the patient to be paralyzed and aware. So if you give the rocuronium, please make sure that you sedate adequately. The onset of action is about 30 to 60 seconds, just like Suck. What you won't see is the fasciculations because it's a non-depolarizing. You won't get that little quivering that you see of all the muscles. So, but you'll feel the patient like is totally loose in about 30 seconds. Lasts about 20 to 30 minutes. So the indications for rocuronium, obviously for RSI, it can also be used post-intubation. So if you intubate with etomidate and sucks, you can give rocuronium afterwards to paralyze for transport. You can't redose it, but you can give it after sucks. It's also going to be used in the induced hypothermia protocol to prevent shivering because when you cool your patient and they start to shiver, that really increases their metabolic demand, and we don't want that to happen. So make sure you give them plenty of sedation, but you can paralyze them to keep them from shivering. There are some patients that are going to benefit from rocuronium over sucks, but like I said, nobody's going to question you if you use one or the other. The patients that you really want to consider rocuronium in are going to be your patients that are high risk for hyperkalemia. Rocuronium doesn't cause the shift in potassium that succinylcholine does. So patients who are already at risk for hyperkalemia, I don't know if anybody's ever seen this, but when you push sucks, all of a sudden they'll have like a wide complex bradycardia. That's bad. Right before they code on you. So your high-risk patients are going to be your dialysis patients, your diabetic patients, especially when they're in DKA, because DKA also causes potassium to shift out of the cells into the bloodstream, and also your burns and crush patients. Now, burns and crush patients really are at risk for hyperkalemia about 24 to 48 hours after their injury. So if you're transporting or occasionally you get the patient that sat at home for 24 hours and finally got sober enough to call 911, maybe 24 hours out from their injury. So in those patients, then you might want to consider ROC instead of sucks if you have to intubate them. The one thing about rocuronium that is, it's really kind of hypothetical. There's really no good evidence for this. And it's the reason why it's sometimes used for pre-induction is that because you don't get those fasciculations from sucks, that it's thought that maybe it doesn't increase the intracranial pressure. So all that muscle contraction is thought to increase intracranial pressure and also pressure in your eyes. The patients that have head injuries or eye injuries theoretically might benefit from ROC instead of sucks. It's given in small doses, like prior to intubation in the hospital. We're not going to use it that way. You just pick one or the other. There's really no absolute contraindications to rocuronium. It might be not as good an idea to use rocuronium in a patient that you anticipate to have a difficult airway. So if somebody's got a big neck, a big tongue, for whatever reason you think they're probably going to be a difficult airway, then I would stick with sucks. Otherwise, if you paralyze them for 30 minutes and you can't intubate them, you're going to be bagging them for a long time. Or putting in a king. There have been a lot of studies about rocuronium versus succinylcholine as far as whether you're able to get the intubation the first attempt. There's really no good evidence one way or the other. This is a study that was done at 4 different hospitals. One of them was Baptist. They looked at over 1,000 patients that were intubated by air care using either sucks or rocuronium, and they looked at the intubation attempts. And there was a slight difference in intubation with sucks over rocuronium, but the confidence interval is 1.1 to 1.8, which means that there really is not a lot of evidence. I mean, it's just barely worth even reporting. And there's many other studies that show that there is no difference. So, and from what I've seen, using rock and sucks, I've never seen a difference. And, it's not harder to intubate one patient over another, whether you use rock or suck. Okay, any questions about rocuronium? Less risk of that than the sucks, yeah. Especially if somebody's got a history of that, I would go with rock. Good question. Has anybody used rock in another county? Did they work in? Yeah. Had pretty good success with it. Amiodarone is a class 3 antiarrhythmic. It's used for VTAC and VFib. It's also used for other arrhythmias. People take this as a PO medication for other arrhythmias, but for our purposes, it's going to be for VTAC and VFib. It has a lot of side effects, none of which we're really going to be concerned about because most of them happen weeks to months after people start taking it. Probably the most serious side effect of amiodarone is it causes pulmonary fibrosis that's not reversible. So even when you stop taking it, it doesn't go away. It can also make your skin turn blue. The vials that we're going to use are 450 milligram vials, and the reason why we chose that is because, and you'll have more than one vial in the truck, but in a lot of circumstances you're going to be using 150 milligram bolus followed by a 300 milligram drip. So the dosing for amiodarone for VTAC with a pulse is 150 milligrams, and it's pushed over 10 minutes. You mix it in 100 mLs of D5W, and all this is going to be packaged together, so when you pull it out, it's all going to be there for you, ready to go. For VTAC without a pulse or VFib, it's a 300 milligram IV push. And then the drip, so we kind of went back and forth about how to mix this to make it easy to use, and we decided to stay with the way that the hospitals mix it just to be consistent. I know the hospitals usually throw away anything you guys mix, but in the off event that they don't, I want it to be the same as what they use. So it's 300 milligrams in 250 mLs of D5W. The dosing for it is 1 milligram per minute, and that turns out to be 50 drips in a micro drip set. The amiodarone drip is going to be used, so if you get the patient back into a good rhythm with an amiodarone bolus, then it'll be followed by an amiodarone drip. Thank you, Brian, for thinking my thoughts. So epinephrine is going to be replacing dopamine as a drip for multiple protocols. It's in the bradycardia protocol, the pulmonary edema protocol, the Ross protocol, induced hypothermia, obviously the hypotension protocol, and also the overdose protocol. And we're going to do the same thing like this with all the protocols so that you guys have a chance to ask questions and clarify things. So this is going to be on all of the protocols that call for epi-drips, so that it'll make it easier to use. We'll put this chart on there. And then the last one is a Zofran ODT. So it's an orally dissolving tablet. The dosing is the same as for PO or IV Zofran. You just put it on the tongue or under the tongue, just like nitroglycerin. It doesn't taste bad, so kids don't mind it. The only thing to be cautious about with Zofran, and I wouldn't overthink this, but there have been cases of people who already have prolonged QT syndrome going into torsades when they take Zofran. There is a black box warning on Zofran because of that. I've personally seen it one time, but it is pretty rare. So patients who either have a known congenital prolonged QT syndrome, which usually they will tell you that, that's a pretty rare thing, but it runs in families, or patients who are on antipsychotics, and these are the ones that you really have to be careful of. So if they're on Haldol, Geodon, Risperdal, Seroquel, any of the antipsychotics, then I would avoid Zofran because those already cause a prolonged QT, and Zofran could potentially cause some complications. If they do go into torsades, you treat it just like any other torsades. And that's it.